very warm welcome to all of you. So today I'm going to be proceeding with the second part of my lecture on minimal intervention dentistry. So just a quick recap as to what I had covered in this class. So I just basically defined what minimal intervention dentistry is and how we have shifted from the era of green body one black and the principle which was the extension for prevention, where we are actually sacrificing healthy tooth structure along with the removal of caries, so that you can actually provide for sufficient depth and width, so that you can accommodate a minimum amount of bulk of respirator material, and you have to create retentive features so that you can actually retain back the respirator material as it does not bond to the tooth. And how this concept has changed ever since the concept of adhesion has been introduced into dentistry, and now the principle which we use is minimal intervention dentistry, and it is based upon the concept of prevention for extension. So we are preventing the extent of your cavity prep so that you can extend the life of your tooth. Then I had discussed the aspects of minimal intervention dentistry, where I had talked about the various tools you can use to diagnose your dental caries in the early stages. Then I had talked about the mountain Hume's classification based on the size and site and extent of the lesion. Of course, we are primarily using the ICDAS technique, but it is always useful to know another classification. So I had discussed the mountain Humes, and then I had also discussed the importance of assessing the individual caries risk of the patients, and then of course you have to modify your treatment. Right, in minimal dentistry, uh, the caries risk and how it how to reduce the caries risk and how it acts the and yeah, the different kinds of ways by which you can perform your minimal intervention, and in the end, so go ahead with the restorative phase. So, in minimal intervention dentistry, we believe in the concept of minimal surgical intervention. So, over here, we primarily focus on the re-mineralization of the demineralized dentin, and we excavate only as and when is required, and only an appropriate amount of excavation of caries is done. So, we do not wish to sacrifice healthy tooth structure, like how I have mentioned in the previous class. We prefer to disinfect the excavated cavities, and we use adhesive restorative materials. So we do not need to create very large or wide. So atraumatic restorative treatment is not a concept which is unknown to you all, because it has been practiced since the early 1900s. So it is basically just the use of your hand instruments, and the use of we are not using the aerators to actually prepare your cavities. We just use the sharp hand instruments like the spoon excavators and hatchets to actually remove the weakened enamel, or to remove the carious enamel, and then we restore it with GIC or with bit and fissure sealant. So in the department of pediatrics, there is another restorative material which can be used, although it looks a little unpleasing. Silver diamine fluoride has shown to give promising results because of its anti-cariogenic effect. So it actually arrests caries, and it does not promote the spread of caries. So it is very good for treating rampant caries, especially in kids. So and it's not something which only the dentists have to do. Even the dental auxiliary personnel can actually apply the silver diamond fluoride, because of which you can actually target a larger population. So that is very beneficial. The only drawback being that it is not aesthetic. So yeah, because of which it may not be very popular. But yes, it is an effective tool against the war with dental caries. Now, coming to the restoration of carious lesions for adults, of course, for the anteriors, because aesthetics plays a major role in our lives now, we have to use anterior resin composites and, of course, with the proper shade matching. However, for non-carious cervical lesions, because of the superior flexural strength, we still prefer glass ionomers. And nowadays, with the advent of resin-modified glass ionomers, they are ruling the market for your treatment of non-carious cervical lesions. So we always prefer to use beautiful, that is your resin-modified glass ionomer cement. So it combines the properties of glass ionomer, because of which you have flexural strength and, of course, the aesthetics of the composite. An advantage of using your hand instruments for excavating caries when compared to the the aeroter is, especially when the caries is equigingival, or sometimes it proceeds subgingival, in most cases of proximal lesions, is that when you're using the hand excavator, the bleeding which can occur will be significantly lesser, because you can actually control the hand instrument and prevent traumatizing the healthy gingival margin. But in the case of the aeroter, of course, you lose your tactile sense, and you are actually working from a further away point, because of which it may not be in your control. So that significantly increases the survival rate of your restoration. And of course, when you are restoring multiple surfaces of teeth, it is best done using composites, because you have to perform only box only cavities. So of course, when we had only amalgams, we used to contradict the use of box only preps, because the retentive features were very less. So now, of course, with the advent of newer materials like composites, which micromechanically bond to the tooth, box only designs are more than sufficient to restore the carious. Now, coming to the concept of bi-layered restorations. In the earlier days, it used to be known by the name of sandwich technique. Somehow, I feel that this term is not very accurate, because let's take it from the layman's point of view. A normal sandwich has bread on both sides, correct? So you have bread on the top and you have bread on the bottom as well. And of course, in a sandwich you have the filling of choice. So it may be mayonnaise, or it may be veggies or meat, or whatever suits you. But the important thing to remember in a sandwich is that the top and the bottom layer are the same. That is your bread. Now, when you relate that to dentistry, if you can see from the diagrams, whether it be the one on the left or on the right, the topmost layer is going to be composite. The layer just below that is your glass ionomer cement, and the material below the glass ionomer cement is the tooth surface. So if you can see, the top layer and the bottom layer are not the same. One is a restorative material and one is your tooth structure, because of which, personally speaking, I wouldn't like to call it a sandwich. So I prefer the term bi-layered restoration, which is technically more accurate. Uh, so, so I just wanted to talk about the two different types of the bilayered restoration. One will be the open technique, which is generally seen in the class 2 cavities, where the proximal margins are involved. So here you can see the glass ionomer cement is actually exposed to the oral environment. And of course, you have your closed sandwich technique, which is seen in your class 1s, that is, you have the occlusal surfaces. So the glass ionomer cement does not actually come in contact with the oral cavity. The benefit of having a glass ionomer cement as part of the restorative material, especially in the open technique, is that because of the presence of fluoride, this glass ionomer cement actually not only protects the same tooth, that is the tooth of interest, it actually protects the neighboring tooth as well, because of the release of fluoride. And another property is that this fluoride can be recharged for the restoration. So when you use your normal toothbrush and toothpaste, the fluoride which is present in your toothpaste can actually get absorbed by your restoration, and hence you are actually recharging your uh, glass ionomer cement with the toothpaste. So then it actually can leach out more fluoride over the years to come. So it works both ways, and it provides a long lasting effect. Now, coming to something known as smart burrs. So these were designed so that for the very principle of minimal intervention dentistry, so that you do not sacrifice your healthy tooth structure. So they are made from glass bead reinforced polymer, and the beauty of these burrs is that it will only be able to cut through your soft carious dentin and your restorative materials. So it cannot. So once it comes into contact with healthy tooth structure, the burr becomes ineffective. So it's not able to penetrate through. So it is only able to remove the softened parts of the tooth because of caries, or it can remove the restorative material. So hence it provides you the platform whereby you can conservatively create cavities. The next step is your chemomechanical caries removal. So in this case, it is just the use of solutions. It comes in a pack of two solutions. The first solution is 1% of sodium hypochlorite, and the second is combination of aminobutyric acid, sodium chloride, and sodium hydroxide. So these two solutions together, when they are used on carious tooth structure, it helps to dissolve the carious aspect, and when you flush it out, you are left behind with healthy tooth structure. So then it can be successfully restored. So this is a very non-invasive kind of a treatment. So you do not end up sacrificing healthy tooth structure. Air abrasion was another popular method which had gained popularity initially, because you can actually create micro cavities. You don't actually end up creating very large cavities because of the size of the burrs which we use in the aero does. So basically, air abrasion, as the name suggests, it uses a blast of air, and this air consists of a stream of aluminum oxide particles, and it is compressed, of course, so it is hit with pressure. And since the particle size is very small, ranging between 25 to 50 microns in diameter, uh, it removes only small amounts of tooth structure. So I have attached a link below, which will actually show you the video. So please feel free to. Next, coming to the laser. The lasers have greatly impacted the field of dentistry, whether it be for soft tissue purposes or, in this case, for the hard tissues as well. So lasers, even in the case of hard tissues, uh, lasers have shown promising results because they provide very specific areas where you can access and actually concentrate your cavity preps, so you don't end up over preparing the surface. When it comes to the hard tissue lasers, you have your Erbium, Yttrium-aluminum-garnet. This is the most popular hard tissue laser. It is good for removing caries and producing microcavities. And the beauty about this part is that if you actually use a hard tissue laser, it actually ends up removing the smear layer, and it produces a pattern which is similar to your acid etching. So actually speaking, when you want to restore it, some articles have even shown that you do not need to acid etch, because that step is already created with the use of the laser alone. So it's quite interesting, but I think a little more studies have to be conducted to actually popularize this concept. I have attached a link below where you can actually see how the hard tissue laser. Calcium hydroxide, the wonder drug of dentistry, it was introduced in the late 1920s. It is popularly used in so many places in dentistry. When it comes to restorative dentistry, it is used for direct and indirect pulp capping, and of course for endodontics, we use it as one of the most popularly and commonly and economically used intracanal medicament as well. So calcium hydroxide work, it actually promotes the formation of something known as a dentinal bridge. So dentinal bridge form is basically when calcium hydroxide comes in contact with your pulp, or when it comes to the surface which is very near the pulp, it starts causing coagulation necrosis. This is because of the extremely high pH. So calcium hydroxide has a pH of somewhere around 11.5 to 12.5. So because of this high pH, it causes coagulation necrosis, because of which there is mild inflammation and the formation of calcium protein complexes just below the superficial necrotic layer, because of which the dentin bridge is formed. So whether it be your direct pulp capping or indirect pulp capping, we generally apply a pinpoint amount of calcium hydroxide. Please keep in mind, when we are applying calcium hydroxide, it is always advisable to apply only pinpoint amount of calcium hydroxide, and that too in the deepest area of the cavity, because calcium hydroxide, of course, is just a sub base. It cannot be used as a proper base because it lacks the strength to actually withstand the forces which are going to be dissipated by the overlying restorative material. So calcium hydroxide will tend to crumble if it is used in large quantities, because of which we use only pinpoint amounts of calcium hydroxide. So the best way of using the pinpoint is to just use the same instrument which is used to mix the dical, that is your dical applicator. So it kind of looks like a small ball puncture. So the moment you mix your dical, you can use the same dical mixing instrument to actually, dical applicator to actually transfer the dical to the site of the restoration where you want to apply it. Of course, we also have the light cure dical, which comes in the form of Terracal light cure. So that is even easier to apply. You just have it comes in the form of a syringe, and you just need to inject a minimal amount and then just subject it to the light cure. So that makes it even more convenient. Now, coming to the question of whether you should repair your restorations or replace it. So please keep in mind, the concept of repair could not have been used in the case of amalgam, because once your amalgam restoration sets, there is no way that it is going to bond to a new mix of amalgam. So the concept of repair was out in the case of amalgams. But in the cases of your present restorative materials which actually bond, like your composites and GICs, you can actually repair them rather than replace them. So when do you know when you have to repair, and when do you know when to replace it? Yeah. So in cases where you take your radiographs and when you can actually see the restorative material is intact, there is no secondary caries attack, and basically it is only a discoloration, a superficial discoloration or a stain which the patient is complaining about, you don't actually need to remove the entire restoration. You can actually just reduce a layer of it, and you can supplement it with a fresh batch of your restorative material. That should suffice, because when you are going to remove your entire restorative material, you are actually subjecting that to the cavity surface to a fresh batch of infection. So it can be prone to another infection attack when you are actually removing the entire restoration. So if it is asymptomatic and if there is no secondary caries attack, I would suggest that you always think of repair rather than replacement. And studies have shown that repairs have lasted for a good 7 to 10 years, if not more. So of course this is the clinician's call, but please do keep in mind that repairs can also be done for adhesive restorations. Okay. So what are the common indications for replacing your restorations? One, when you have a marginal void. Of course, so if you see that there is a break in your in the breach of the continuity of your restorative material, of course, you know that it's time to replace the restoration. When there is poor proximal contour, so please remember contacts and contours are very, very important. Or if there is a gingival overhang, then yes, it's time to get rid of that restoration and actually do a proper one. If there is recurrent caries, so this is what I was talking to you about. So if there is recurrent caries attack, then of course yes, it cannot be treated adequately by repair. It has to be re-restored again. And when you see that there is pitching deeper than 0.5 mm of the previous restoration, so in that case, of course, it means that the caries has actually gone below the restoration. So there is a very good chance that it has contaminated below the undersurface of the restoration also. So it's time to remove it. Yeah. So where do you actually think of doing a repair? Is like I said, when there is only light marginal staining. So in this case, you can deem it as non-carious and it can be corrected by a shallow repair. And replacing, like I said, does not necessarily guarantee that the new restoration will surpass the performance of the previous restoration. Yeah, and it does not necessarily mean that it will surpass the performance when compared to repair as well. Like I said, studies have shown that repair of restorations also have lasted a good 7 to 10 years, if not more. So, of course, in the end, it is the clinician's call as and when he sees the condition of the tooth and the condition of the patient. It is for him or her to take. So, generally, replacement should only take place if the practitioner cannot properly manage the defective areas without removing the entire restoration or if there are multiple symptoms. Okay, so now just a brief revision because I'm sure this has been covered in the previous semesters also. Uh, the difference between infected and affected dentin, this is very, very important, especially when you are dealing with deep caries management cases. So it's always good to know which can be left behind and which has to be removed. Always remember the infected dentin, which is the soft and which is the moist part of the dentin. This is the non-re-mineralizable one, so this has to be removed. Under no circumstances is it to be left behind until and unless the patient has decided that the patient does not want to get the tooth restored and wants to just keep it for wait and watch until it causes problems and he just wants to get the tooth extracted, which is a very sorry state. But yes, it has been shown to have happened in the past. So this is the only option where you actually leave behind your infected dentin. Otherwise, we do not want any infected dentin to be left behind in the cavities. Affected dentin, yes, we can leave it behind. Again, I'm stressing on the word can. It doesn't mean that it should be left behind. It can be left behind if the cavities are going too deep. So in deep caries management, when you feel like you are approaching the pulp, uh, you have to prepare your cavities judiciously, and in such cases, you can actually leave behind your affected dentin. And of course, when you apply your dical or your terracal, it helps in the formation of the dentin bridge, because of which the affected dentin moves more and more occlusally away from the pulp. But this, of course, does not happen overnight. It happens over several months. So you have to keep on recalling the patient every 6 months, and with the help of radiographs, you can actually evaluate the status. So you will see the gradual rise of the caries away from the pulp. This happens because of the formation of the dentinal bridge, which I had discussed in the previous slides. So this is what I was telling you about. That studies have shown that repair has remained stable for 7 to 10 years as well. So it's not deemed unnecessary to be done. And of course, here we have the caries risk assessment. This is what I was discussing in the first lecture. So these are the criteria you have to keep in mind before you assess the patient's caries risk. You have to take a brief dental history. You have to assess the diet of the patient. Clinically, of course, you have to take a call based on the number of new carious lesions which have come, the number of teeth which have been extracted because of caries, the patient compliance, whether he or she is willing to actually modify the diet and practice proper oral health care guidelines. What is your opinion as a clinician, whether this change can be brought about or not? And then, of course, you categorize the risk of the patient into low, medium, or high. And depending, you have to recall the patient. So for low and medium to moderate risk patients, roughly biannual recall should suffice. Once in 6 months is pretty good if the patient can make it for regular checkups. But of course, if you have your high risk patients, it is always advisable to recall the patient every 3 months because you need to keep the caries in check, the new carious lesions in check, and you this fluoride treatment so that you can actually arrest the carious lesions or prevent the spread of new carious lesions on the remaining teeth as well. Okay, so this was about the restorative phase of minimal intervention dentistry, and this brings a close to the chapter. I hope this lecture has been of some value and you have been able to imbibe some useful information. If you have any doubts, please feel free to contact me. I'm always approachable. So this is bye from my side. Stay safe and keep in touch. Okay, take care. Bye bye.